key points that you need to know for your proctors and exams. Okay, so we're talking about upper respiratory and lower respiratory um, disorders in this presentation. So just overall, for health promotion and disease prevention, everybody needs to use really good hand hygiene techniques. You want to encourage everybody to get the immunizations they need. I've been having a pneumovax every 5 years since I was 10 years old because I don't have a spleen. And thank goodness I've never had pneumonia or meningitis. Those are the two things I'm prone to. You want everybody to stop smoking, limit alcohol. Remember what I said about alcohol. Limit exposure to allergens. Cover your mouth and nose with a tissue. If you don't have a tissue, don't sneeze in your hands or cough in your hands. Turn your head to the crook of the arm while coughing. Okay, that's the proper way to cough if you don't have a tissue. All right, so the first condition is rhinitis. This is just a common cold. The big thing is people think they can get antibiotics to cure it, and they cannot because it's a viral infection. They just got to write it out. Sinusitis is inflammation and infection in the sinuses. Now, the big deal with sinusitis is because of the proximity to the brain, the patient can develop meningitis from this. Meningitis is inflammation of the meninges of the brain. So the layers that surround the brain are the meninges. So if those get inflamed, the patient's going to be quite sick, okay, with that. So we're going to talk about that a little bit later. Pharyngitis, bacterial and viral, those are the two types. With bacterial, we worry with streptococcal pneumonia because the patient can develop meningitis. They can develop rheumatic heart fever, They can also develop something called glomerular nephritis, which you'll learn in pediatrics. Okay, so recognizing cues, they all have basically the same signs and symptoms. And if you've had a cold before, you know what those signs and symptoms are. All right, and then we treat it just symptomatically. Okay, so increase fluids, get some rest. If somebody has a fever, this is just general, anybody with the fever, usually they're okay until 102.2. But you want to administer antipyretics. Acetaminophen is probably the most safe antipyretic to give adults, except adults with liver failure. But for the most part, acetaminophen is an antipyretic to give. No aspirin to anybody under the age of 18 if they have a viral infection, and you learn about that in pediatrics, but that's super important. Fever is going to could make them dehydrated because it revs up your metabolism, so provide fluids. Prevent shivering. You don't want your patient to start shivering. It boosts your metabolism. And also don't put like ice in the groin, in the axilla, because that can cause them to shiver. Provide oral hygiene, trend their temps, monitor the WBC. Always, you want to get your cultures before you start antibiotics, and you can use a cooling blanket and set the room temp 70 to 80 degrees Fahrenheit. Okay. Now, I think I already touched on the complications of pharyngitis and sinusitis. Okay, so they're going to need droplet precautions. Super important, which conditions need which kind of precautions. And I'll go into a little more detail later. But basically, we're talking about respiratory disorders. So most of them are going to need droplet precautions, except for TB that needs airborne. Okay. Now, the reason, if somebody does have sinusitis or pharyngitis and they suspect meningitis, the patient's going to need a lumbar puncture. Okay. So beforehand, it is an invasive test. A lumbar puncture means they're going to do a spinal tap. Okay. So they need an informed consent. So the provider's going to have to, inform the patient of the procedure. Cannot be done if they have either increased intracranial pressure, because that can mean their brain can herniate down out through their skull. And we don't want that, right? Nobody's got time for that. So, and one of the first signs of increased intracranial pressure is a change in LOC. The patient can become sleepy, lethargic. They can become irritable and become ornery. So something is out of whack for them, okay? That's early signs. Anybody with bleeding disorders cannot have an LP. You remove jewelry, like all procedures, you have your patient void beforehand, and take vital signs, and you're going to do a baseline neuro lower extremity assessment. So, have the patient push on your hands and pull up with their feet, and, just see how the legs are moving. They're going to be placed in a cannonball position. So fetal position, but more tight. Okay, cannonball. All right, post LP, you're going to send the specimens to the lab. You're going to do the vital signs and post neuro assessment of the lower extremities. Monitor that puncture site, make sure it doesn't have a hematoma. The client has to remain flat for several hours, like it could be up to 12 hours. And the reason for this is it's to prevent cerebral spinal fluid leakage, and it can cause a major headache, like a headache that doesn't go away. So we want to prevent that. And we're going to encourage fluids to replace the fluid lost. And so those are the interventions. Keep flat, give fluids. All right, cancer of the larynx. Okay, so that's smoking and alcohol are the leading causes. I'll tell you that right now. Usually what happens is the patient will have a hoarse voice, or they'll be coughing for a long period of time. So they need to really go see a provider by then. It does have a good prognosis. Radiation treatment can treat like 85% of the cases. But if they need cancer surgery of the larynx, okay, they're going to have a total laryngectomy or a partial. So what they do is they bring the larynx out, okay, much like you would see a tracheostomy. All right. And so this is a major surgery. It's a major change for patients. So we have to really, attend to their mental health issues. But also, when they do this surgery, it's a big surgery. So the patient's going to be inflamed and around their esophagus. So they may not be swallowing well. Now, the person that you collaborate with to get swallowing assessed is a speech therapist, okay? The speech therapist comes and evaluates swallowing on people that are like at risk for aspiration, post-stroke, post-laryngectomy, and they're the ones that order like thick liquids or thin liquids, depending on how the patient swallows, okay? Now, because they may not be eating well, they usually get a feeding tube placed with the surgery. But because they're not going to eat well, they may be prone to malnutrition. So you need to know how to assess for malnutrition. Okay. So, review the signs and symptoms like lost weight, lost muscle mass, delayed healing, because this is a big surgery, right? So we need to make sure that they can heal. Confusion, lethargy, apathy, fatigue, weakness. They can't concentrate. So bleeding gums, enlarged liver and spleen, so the organs get bigger. ATI loves the changes in hair. So dry, brittle hair, depigmented hair, so they lose like the color. And again, collaborate with the speech therapist to assess swallowing. Because they will eventually be able to eat real food again. With the tracheostomy, now what happens with the laryngectomy is they will put like a trach tube in for a short period of time, and then they'll eventually take the trach tube out, and the patient will just have a stoma where the larynx is in their neck, and they breathe through that, okay? So you want to, obviously, your main goal is always to maintain that airway, so you're going to suction PRN. Okay, we never suction on a schedule. We only suction if we start to hear that the patient needs to be suctioned. So auscultate the lungs before and after to see if you've made any improvement. Suctioning is always going to be strict sterile technique, surgical asepsis. You can use humidification of O2 to thin secretions. It's a great intervention. They're probably wearing oxygen anyway. So the other thing for thinning secretions is to drink 2 to 3 liters of fluid per day. but adequate humidification is also a great intervention. If the patient is gonna, if you're gonna deflate the cuff of the trach for any reason, you have to suction the mouth and the back of the throat beforehand. Otherwise, anything that's there is gonna go right into the lungs. You have to establish a communication method with patients, okay? So you can ask those like post laryngectomy, and this can go for anybody that can't speak, like somebody that was intubated, tracheostomy, somebody aphasic, so somebody that can't speak to you, okay? So ask yes or no questions to assess if they can understand you. Provide with alternative methods of communication such as paper and pencil writing, communication boards that usually have the basic needs of patients on it and they can just point to what they need, like a pain scale with the faces on it, that too. They can write on, text on their mobile devices so you can read it. And then with laryngectomy, you need to protect the stoma, okay, once that trach tube comes out. So they can't swim, obviously. You want to prevent, from lint and dust getting into that stoma. They're not going to be able to talk if they had a total laryngectomy, so that can also make them feel powerless. They can get a external electronic larynx and hold that against their throat to vibrate the sound and talk. Okay, so conditioning, we're going to switch gears now and talk about mechanical intubation or intubation. Okay, so I'm going to give you some broad examples of people that may need intubation. Somebody with respiratory arrest obviously is going to need to be intubated. Somebody with hypoxemia. Now, hypoxemia is defined as having a PaO2 less than 80, okay, because the normal is 80 to 100. You expect older adults to have lower PaO2s, but once it gets to 60, it's time to intubate. And usually those are people with like acute respiratory distress syndrome, so ARDS. Anybody with a Glasgow coma scale less than 8, it's time to intubate, okay? So just remember that. All right, so yeah, that's it for lower respiratory, upper respiratory. Now we're going to talk a little bit about lower respiratory. Okay, for upper respiratory, let me just bring this back up to the top. Okay, for upper respiratory, we have conditions such as influenza, and I think you know what influenza is. The big thing is droplet precautions. It's highly contagious. So if you have somebody in the hospital with the flu, they need droplet precautions. And so remember what goes into droplet precautions. You have to wear a mask, clean hands, and a mask to walk in that room, okay? With anybody with like respiratory problems, we want them to drink a lot of fluids, especially if they have a fever, but also because it thins secretions. So pneumonia. Now with pneumonia, this is an inflammatory process. It's, the lungs produce excess fluid and mucus, and it could be caused by either organisms like bacteria or viral organisms or irritants like somebody aspirates, okay? And so they get aspiration pneumonia. There are several types of pneumonia. There's community-acquired pneumonia. That's the most common. So somebody's living out in the community, they get pneumonia. Or if they come into the hospital with pneumonia, they get symptoms within 48 hours of coming into the hospital. That is considered community-acquired pneumonia. Healthcare-associated pneumonia is pneumonia that occurs 48 hours after admission to the hospital. Same with hospital-acquired. Ventilator-associated pneumonia is associated with patients on mechanical ventilators. And what we discovered is just by providing really good oral care with chlorhexidine, it can help decrease the chance of getting pneumonia. So you have a lot of bacteria in your mouth, and so if you swallow it, it can get down to your respiratory tract and cause pneumonia. So oral care is key. Now, there's a lot of risk factors, obviously, smoking and alcohol, again, just like I said, and age. All right. So recognizing the cues. Okay. So with pneumonia, like most conditions we will be talking about, tachycardia is going to be a key sign, okay? Tachycardia occurs in a lot of conditions, and it's usually the first sign in a lot of conditions because the body is under stress. So it is a sympathetic nervous system response when we are under stress. Okay, so that's the first sign. Headache. They could have diaphoresis. Pleuritic chest pain refers to pain when breathing. So the patient will usually complain of a sharp pain while breathing in. So sharp pain on inspiration. They'll have tachypnea, okay? So tachycardia and tachypnea. That's why you really have to count respirations. It's really important. They could have organ failure. Their O2 sats could be low. They're going to have fever, and I already talked about fever, how to take care of that, and cough, okay? Consolidated lungs. That's what the x-ray is going to show. All right, diagnostic tests. Now remember, older adults may have pneumonia, all right, but you may not see a fever in older adults. So you have to remember that. So if somebody comes in confused, tachycardia, tachypnea, but they don't have, you're going to have to advocate to get a chest x-ray for that patient. All right, so they will have high white counts, which you may not see in older adults as well. The ABGs will show hypoxemia, so a PaO2 less than 80. All right, electrolytes, depending on if they're dehydrated. You're going to send a sputum for CNS, and they'll have a chest x-ray and possibly blood cultures if they think they're getting septic. All right, so some of the interventions. Okay, if you have anybody with any condition that's dyspneic, the first thing you're going to do is get that head of the bed up because it's easy and it's quick and it takes less than 30 seconds. Okay, obviously they'll need oxygen, right? If their O2 sats are low, you're going to encourage turn, cough, deep breathe. We got to get them moving, right? Remember your frequencies, Q1 to 2 hours. You suction only PRN. Anybody with a respiratory condition that causes dyspnea is going to increase their work of breathing. That work of breathing is going to increase their metabolism, which increases their need for high quality protein foods, okay? So you need to increase their calories, and the fluid intake needs to be 2 to 3 liters a day to thin those secretions. And 8 glasses of water per day is a good goal to set for your patient. All right, you're going to provide emotional support during dyspneic episodes. Never leave a patient in distress alone. Call for help. All right, and obviously your patient's going to be exhausted, so provide rest periods for your patient. There's a lot of medications that you'll be learning in pharm that can help treat pneumonia. You need to be able to distinguish early hypoxemia from late hypoxemia. Students always want to tell me that cyanosis is a symptom of hypoxemia. It's a symptom, but it's when they're circling the drain that they get cyanotic, okay? So you need to know these early signs, like it's imperative, because if you give me a report that your patient has had all these symptoms all day and I go in the room and the patient's cyanotic, you missed everything that happened all day, okay? I'm going to think poorly of you. So the first sign you're going to see besides tachycardia and tachypnea, right, is restlessness or agitation, anxiety, confusion. Those are early. The skin will be pale, it'll be moist, use of accessory muscles, and their blood pressure will be up, okay? With late hypoxemia, the heart's going to just go slow, okay? They'll have extreme restlessness, dyspnea, dysrhythmias, and their skin will be cyanotic. They will become stuporous. Okay, stuporous means like lethargic, like you're not going to be, you'll have trouble waking them up. Okay, so you have to know the difference. All right, the next condition is TB, highly tested, super important. It's spread with somebody with TB of the lung, coughs, sneezes, talks, or sings. Okay, so they're going to need to be on airborne precautions if they're in the hospital. The risk factors include living with somebody that has TB, people from lower socioeconomic statuses because they live in close quarters with a lot of people, like immunocompromised people, people that live in prisons, um, college dorms, those kind of things. Okay, advanced age, a recent travel to a country that has a high incidence of TB, substance abuse, and healthcare workers. Those are the risk factors. All right, how to recognize cues. Super important. These are classic symptoms. You have to recognize them because if you have a patient, like say you're working in the ED, and you have a patient that comes in with these classic symptoms, you got to get them away from people in a room by themselves. They need a negative pressure room if you have it would be great because they need airborne precautions. Okay. So the recognizing cues, cough times 3 weeks, fatigue, okay, lethargy because they've got an infection, right? Low grade temperature in the afternoon. Ding, ding, ding. That is key. It has to be in the afternoon. Night sweats. So if I hear somebody that has a low grade temperature in the afternoon and night sweats, I'm already thinking TB. Those two symptoms alone, I would get them away from everybody, okay? Anorexia, weight loss, and then they can have like hemoptysis, coughing up blood, and purulent sputum. These are the classic symptoms. You need to know them. You need to recognize them. So what you're going to do, they need a negative pressure room because they need to be put on airborne precautions, which means they have to be fitted for and wear an N95 mask. Nurses do, right? N95 mask. The client wears a surgical mask to travel. Like if they need a chest x-ray, you're going to take the quickest non-populated route that you can. Usually, like every hospital I worked on, there's always like a back way through the back hallways to get to places like X-ray. You're going to make sure the client puts on a surgical mask to travel. Okay, if they leave their negative pressure room, they have to wear a surgical mask. Teach to cough into tissues. I talked about respiratory hygiene earlier. Encourage fluid intake, and they need food rich in protein, iron, vitamin B, and C. Now, the treatment is long, extended, and it entails multimodal medications that you're going to be learning in pharmacology. And on your pharm proctor, I'm sure that's going to be highly tested. Okay. COPD is the next condition we're going to talk about. It comprises two conditions, but usually they live together. Patients have both of them, chronic bronchitis and emphysema. I'm not even going to break them out, okay? With COPD, chronic bronchitis is inflammation of the bronchioles, and they'll have like mucus production. With emphysema, they have air trapping in the alveoli, so they have trouble like with exhalation because the air is trapped, okay? So at risk, people that smoke, that's the number one problem, okay? There's others, but that's the number one thing. Recognizing cues, okay? These are key points. Patients are going to have a barrel chest, and I'm going to show you a picture of that. They will also have what's called club nails, and I'll show you a picture of that too. They're going to have thin extremities and enlarged neck muscles because the neck muscles help pull up the shoulders. And when people can't breathe, they lift their shoulders to try to get the lungs to expand more, okay? Thin extremities and large neck muscles. So remember that. Decrease in O2 sats, yes. Right-sided heart failure, and we'll talk about right-sided heart failure in another lecture. They're going to have lower extremity edema due to the right-sided heart failure. All right, chronic dyspnea. They'll have dyspnea on exertion, so any kind of activity is going to make them dyspneic. They'll have hypoxemia, so expect the PaO2 to be low. Crackles and wheezing. Respiratory acidosis, okay, because they're breathing fast, so they have tachypnea, but they're shallow respirations, okay? So they're holding in that CO2. They're a CO2 retainer, okay? So this is a picture of club nails right here, and then this is a picture of a barreled chest. And this happens because the lungs in COPD hyperinflate. So like because they have trouble, they have air trapping, so they're hyperinflated. All right, so for your nursing care, put them in high Fowler's or orthopedic. Orthopedic is considered tripod conditions position. So they could be like sitting up and tripoding by putting their two hands on the side of the bed and leaning forward. That's a classic position. You can Google it. They could also use, you could also, if they're like really exhausted and having trouble sleeping, put a bedside table, in front of them with a pillow on top, and make sure it's locked, and so that they can rest a little bit. Encourage use of incentive spirometer. Have them deep breathe and cough at least every 2 hours. Remember your frequencies. Breathing treatments and medications will be ordered, and they'll have those around the clock. Maintain the O2 sat 88 to 92. Somebody has COPD. I expect the O2 sat to be 88 to 92. So I'm not going to be overly concerned if it's that low, okay? Because that's what I expect. They should be put on 2 to 4 liters of nasal cannula, or 40% Venturi mask. Venturi mask is really great for people with COPD because it's more accurate. It's a more accurate delivery of oxygen. They're going to need to eat soft, high-calorie foods because the work of breathing is going to increase their metabolism. They need to increase fluid intake, but not during meals. When you want to get somebody to eat more, you try to give the food without all the liquid, okay, so that they're going to need high protein foods, and they're going to need to sit up for 1 hour after they eat, okay? You never want them to go lie down because it's going to be too hard on their breathing to have a full stomach and lie down. Now, there's types of breathing that you can teach them. One is pursed lips breathing because they have a problem with exhalation. So they form their mouth like a whistle, and you say, breathe in through the nose and out through the lips of the mouth with pursed lips. Okay, so pursed lips is when they form like a whistle, okay? They shouldn't puff their cheeks and take breaths deep and slow. And you might have to stand by the patient and coach them through this if they, are really anxious. Diaphragmatic breathing is another type of breathing, but most of the questions I see on ATI are about pursed lips, okay? And with the diaphragmatic breathing, they have to take deep breaths from the diaphragm. So they have to lie on their back with their knees bent and rest their hand over the abdomen to create resistance. But they are going to be able to do pursed lips better than diaphragmatic because they're not going to be able to lie flat on their back. All right, so key points with COPD: stop smoking. They could go to a respiratory rehab program, which will help them, teach them how to do ADLs with their disease, but also help with exercise tolerance, okay? So nutrition, extra work of breathing, remember that. They need extra protein, and they have to stay upright after eating and maintain a normal weight, because if you're carrying extra weight, it gets harder to breathe. Incentive spirometer, good for all the, pneumonia. It's good for somebody with pneumonia, somebody post-surgical, somebody with COPD. It is very hard to do. I've tried this. It looks easy when you see somebody doing it, but it's not. Okay, so you have to tell them to keep a tight seal around the mouthpiece, and they inhale and hold their breath for 3 to 5 seconds. And then when the needle rises, that's when the lung expands, okay? So like a patient post-surgical, or, you might put the goal at, see how they do on their first one, and then put this little marker as their goal, okay? But tell them to start slow and increase volume over time, because they're not going to be I see very few people get up to 4,000, okay? So it's going to take time for them to increase their volume. All right, pulmonary embolism. I'm going to switch gears now. Now, a PE can happen after somebody has a DVT, when the clot breaks off and goes to the lungs, okay? It's going to be sudden. Anytime somebody has an embolism, the symptoms are sudden. Okay. So we've talked about DVT before and some of the conditions. I have acute mnemonic here, but for your purposes, this semester we've talked about long bone fractures can result in fat emboli. And then the symptom that is indicative of that is a petechial rash across the chest. We talked about surgery. We talked about smokers, people that are immobilized. I know you had that in fundamentals. Okay. So here are the symptoms. They're sudden, right? Somebody suddenly is going to get short of breath. All right. They're going to have chest pain on inspiration, which is called pleurisy. Okay. Remember that. Pleural friction rub, cough. 10% of the people that get a PE die instantly. Okay. That's why it's so, what you do as a nurse is so important, super important to prevent that DVT, first of all. Okay. Tachycardia, because the body's under stress, they're going to have a fever. They'll be anxious or have feelings of impending doom, because anybody that's hypoxemic is going to have feelings of impending doom. Okay. Your brain likes oxygen, and when it doesn't get it, it starts to get pessimistic. Okay. So they're going to have hypotension and hemoptysis. Okay. So those are the signs are sudden. Okay. So treatment is going to be oxygen, anticoagulants that you'll be learning about in pharmacology. Those are the two main treatments. Inferior vena cava filter. I have another slide. I'll show you about that when we talk about venous problems. So nursing management, stay with your patient. Never leave a patient in distress alone. Get the head of the bed up, put the oxygen on, remain calm, call a rapid if you have to, okay? All right, so chest tubes. We're going to talk briefly about chest tubes. So chest tubes can be used for a lot of different reasons. It could be after chest surgery. It could be your patient has a pneumothorax. So the location of the chest tube, if they're trying to drain air, the chest tube will be placed high in the lung. And if they're trying to drain fluid, it'll be placed low in the lung, okay? So chest tubes are all based on the same 3 chambers or principles, okay? So you have 3 chambers. One is the collection chamber. This is what collects all the drainage. Like if somebody is had lung surgery and they expect them to have a lot of fluid draining, you would see it in that chamber. It also, the water seal is the next chamber, and this performs an underwater seal to allow air to be released into the chest tube from the pleural space, but the air cannot go backwards, okay? Suction control chamber, this provides the suction that the physician will order, and it's usually always -20 centimeters of water. Okay, so this is the drainage collection chamber. So if it slows down, look for kinks in the system. Now, your patient that had a pneumothorax may not even be draining any fluid, okay? Somebody that had surgery, maybe. So you want to make sure that your lines aren't, your chest tube is not like kinked off. But this is the collection chamber. It needs to remain below the level of the chest so the chest tube can drain and do its job. All right. The next chamber is the water seal chamber. Super important you know this. Water oscillates or tidals or moves up and down in this chamber when the patient breathes. This is also where you look for an ear leak. You do not want to see constant bubbling in this chamber, okay? So if the water stops oscillating in this chamber and the patient had a pneumothorax, that means the patient's pneumothorax may have healed, or it could mean that the tube is kinked off. Your patient is lying on it, okay? So you would look for that too. So again, here is the water seal chamber. This is an ear leak meter. You would look for bubbles in here, which indicate an ear leak, okay? You don't want to see bubbles. Now, if somebody did have a pneumothorax, you may see one on expiration, rare bubbles on expiration, but you never want constant bubbling here. And over here, I don't know if you can see my mouse, but this is where the water will oscillate with breathing. All right, so that's important to know. You want to make sure the patient is engaging in pulmonary hygiene, never strip the tube, and keep it below the level of the chest. Okay, your patient should be in high Fowlers. They do a chest x-ray after insertion. All right, so the drainage you're looking for, if it's greater than 70 an hour, you have to report that. All right, so next thing, the only other thing I want to talk about is transmission precautions, because you really got to like know this inside out. And I know you had it in 110, and so it's important. So the ones we're focusing on, right? We did tuberculosis, so that's airborne. So your patient, so you need to be wearing an N95 mask. The patient needs to be put in a negative pressure room, and if they need to go anywhere, they need to wear a mask. Okay. Talked about that. The other thing, wash your hands. Everybody needs clean hands, and we can use alcohol-based unless our hands are visibly dirty. Then we have to use soap and water. And if they have C. diff, which is contact, which I'm not talking about right now, but that's the other reason you would use soap and water. All right. So airborne, remember the mnemonic MTV. So measles, mumps, tuberculosis, and herpes zoster. So that's a shingle rash. Okay, that's for some reason students always forget that that's airborne. That's really important. And then with droplets, okay, so we talked about the flu. We talked about streptococcal pneumonia or streptococcal, pharyngitis. Um, Also, it could cause, meningitis. Okay, so all these pneumonia, rhinovirus, so all these things are respiratory conditions that need droplet precautions. So with droplet precautions, you need clean hands and you need a mask. With airborne, the patient is definitely going to be in a private negative pressure rooms. Usually there's only a couple on your floor, right? Where I worked before, there was usually one on the floor, one negative pressure room on the floor. So the patient will be in that. When droplet, of course, if you can, you put them in a private room, that would be best. However, if you have to cohort them with somebody else, make sure they're within 3 feet from the other patients, and hopefully the other patient, if has the same condition, the same, like if put 2 flu patients together. Okay. Now, if this patient, droplet precaution patient, has to travel, they need a mask as well. Okay. All right. So that's what we're going to focus on this exam.